Today we're talking about kidney transplants. Here's a picture for you. Fewer than 4% receive a transplant. Most of our patients unfortunately die waiting for transplants. 17,000 approximately, and these are nice to know numbers, take place, and 100,000 are still waiting. So clearly there's not enough for everybody, right? And some people wait, and a lot of them die waiting, sadly. So the average wait for a cadaver donor is like 2 to 5 years. But these surgeries are very successful due to low cold times, and we're going to talk about that. So they're like 90% successful for a deceased donor, 95% successful for a live donor. So, and we're going to talk about what those exactly mean. I know you haven't had that yet, but just so you know that the surgery itself is very successful. Advantages. They reverse many of the effects of renal disease, eliminating dependence on dialysis machines. There's less dietary and less, lifestyle restrictions. And after a transplant, it's less expensive after the first year. So that is a big consideration for a lot of folks. So due to the perfection of procuring organs, surgical techniques, tissue typing, and prevention of rejection, the surgery itself has been really successful. And renal failure can be reversed once kidney function is renewed. And we talked about improvement with lifestyle. You're not attached to a machine anymore, so it really does give them a lot more freedom, a lot more independence. Can I go on? Okay. So we're talking about contraindications. Not everybody can be a candidate for a transplant, but they really do try to alleviate the contraindications and make them candidates for the surgery as much as they possibly can. I know I worked with organ procurement organizations, or OPOs, closely, so I know these people are extraordinarily devoted to what they do and finding matches and recipients and donor matches. And they are wonderful people. They go to extraordinary lengths to make people good matches. It's their lifetime devotion. If anybody's interested in doing that, I can find somebody to talk to for you. But I don't know if y'all have heard of LifeLink. Yeah? Y'all heard of LifeLink? Okay. So that's one of our...
Really hard to see. I'm sorry.
What's that?
Does that say drug abuse, alcoholism?
Yeah, the light blue just says drug abuse, alcoholism. So, yes, and these are contraindications, disseminated malignancies, which just means that they have malignancies spread everywhere. That's what disseminated means. Untreated cardiac disease. So that means that if people have heart disease, and most of these patients do, most of them have multiple comorbidities like diabetes, heart disease. So what they'll do is they try to treat their disease. Maybe they need bypass surgery. I know one of our leaders at Largo Medical Center, she was not a candidate, and then when she got her bypass surgery and treated her cardiac disease, made some lifestyle changes, then she became a candidate again. Also, chronic respiratory failure, extensive vascular disease, unresolved psychosocial disorders such as drug abuse and alcoholism, HIV and Hep B and C are not contraindications. Okay? And chronic infections. For obvious reasons, right? Yes?
Can you give an example of disseminated malignancies?
Sure. I would say mets to the bone when they're metastasized, like spread everywhere, brain cancer, someone who has a poor prognosis. Good question. And sometimes with people with polycystic disease, they won't do them with those kinds of illnesses, or things that sometimes can recur. And we'll talk about those, like glomerulonephritis and stuff like that. Sometimes some kidney problems can recur down the road. So we're going to talk about recipient screening. They do select carefully to minimize complications. This is a process. It takes time. Patients with cardiovascular disease or diabetes are very high risk. Some patients will also be considered if they stop smoking, but they may not take them if they fail to stop smoking, even with cessation attempts have failed. Okay. But if they're in a program, they will consider it. And of course, some people are higher risk than others. The higher risk patients are considered a priority, but they use a point system to screen patients to make sure they're candidates. But they will look at the medical, the psychosocial history factors, and all of the factors in considering selection for transplant. Okay, so then we're going to talk about histocompatibility studies. I don't mean for you guys to memorize all this. This is kind of nice to know, but it's important that you know how matching plays a key role in the success of kidney transplants. So when we look at histocompatibility studies, it's on page 206 and 207. That is part of your reading, recommended lecture reading. HLA antigen system is used for matching organs and tissues for transplantation. Antigens are responsible for rejection. So they do careful tissue typing and cross-matching. So tissue typing, the recipient receives a transplant from an ABO donor group. The donor and the recipient do not need to share the same Rh factor. Like I said, this is nice to know. You don't have to know this by heart. HLA typing is done on potential donors and recipients to attempt to match as many antigens as possible. The more that are matched, the less chance of rejection. So sometimes the best may be far away, and it can be like a race against time to bring the donor and the recipient together. So a positive cross-match means it's contraindicated to proceed with a transplant. A negative cross-match means it's safe to proceed with a transplant. ABO incompatibility is resolved using plasmapheresis. Any of you ever heard of that, plasmapheresis? That's why they use that. Okay.
So blood type doesn't matter?
It does matter, but they look more for antibodies.
Okay.
Yeah. So they use, they detect antibodies. The way it works is the recipient serum is mixed with the donor lymphocytes, and they can use, if patients are really highly sensitized, they will use the plasmapheresis, which is IG, and that lowers the number of antibodies. So the transplant candidates are able to receive kidneys from live donors with different blood types because of the plasmapheresis. And they were once considered incompatible. So it truly is amazing what they can do to match folks, if you think about it. And cross-matching is done to determine the antibodies against the potential donor. Uses of serum from a recipient is mixed with the donor lymphocytes They detect any anti-HLA antibodies to the donor organ. So negative cross-match means there's no antibodies, so it's safe to transplant. Positive means it's not safe. Can I advance this slide? You guys good? Okay. All right. So types of donors. Can be live, family, friends, relatives, or they can be deceased, and they're called cadaver donors. Okay. And there's also such thing as paired organ donation. When a donor or recipient are not compatible, they can be paired with another donor or recipient pair. It's very interesting how they do that. Do you imagine? So live donors, extensive evaluation is done for these folks to ensure they're in good health and they have no history of diseases that would place them at risk to developing any kidney disease or any complications. Cross matches are done at the time of evaluation and a week before transplant again to ensure no antibodies to the donor are present or that the antibody titer is below the permissible level. These are much better survival rates, and it's immediate organ availability. There's really limited cold time with a live donor transplant, which means cold time means the time that is the organ is outside of the body with no circulation. Kind of like on ice. I know that sounds kind of morbid, but So again, extensive pre-screening. And donors must be explained the risks and the benefits, the short-term and long-term complications. Like I said, the survival rate is high due to low cold times. The kidneys are revascularized much faster. Okay. But we can't forget our donors once the procedure's done, right? Because these people went through extraordinary lengths to give up their kidney. And sometimes they feel like they've been just dumped afterwards, and you don't want them to feel that way. You want them to feel a value, and that what they did was really meaningful.
Do you guys know, like if you're the donor, you really can just carry on with your life as usual?
Mm-hmm.
You don't be less.
No, your other kidney pretty much takes over. You really have no... you do have to be careful not to harm your other kidney because you only have one after that,
That's it.
But yeah, but it's normal function, yeah. Pretty amazing, huh? I know I had a friend who was born with only one kidney. And she was fine until she became a baker. And she was sweating, losing all these fluids in the bakery and not drinking enough. And she got real sick because she was losing her only one kidney. And then she found out when she went she was in France, and then when she found out she only had one kidney, so then she knew, oh, I better take care of it, right? So cadaver donors are a little different. A couple other things I wanted to tell you about the live donors too. They do a lot of pre-screening. Before the surgery, they'll do like an H&P. They'll do like a 24-hour urine for creatinine clearance. Some other tests would be like a CBC or typical pre-op tests. They screen for hepatitis, CMV, all those diseases. Also, EKG, chest x-rays are done. And they'll do like a renal ultrasound. And this is all in your book. But they will do extensive screening. They will also do psychological counseling for them before they go through the procedure. And of course, they're informed about any potential complications. And recovery is about 6 weeks. So it's a pretty quick, safe surgery, and a pretty fast recovery.
For the donor.
Yes. Okay, so for the deceased cadaver donors are people who were relatively healthy and then who suffered an irreversible brain injury and were declared dead. So most commonly it would be a motor vehicle accident, gunshot wounds, intracranial hemorrhage, anoxic brain injury from an MI. So the brain dead donor must have circulation and mechanical ventilation to preserve organs. So just because they're a cadaver donor, their organs still need perfusion. Everybody understand that? You must have perfusion to be a cadaver donor. So yes, they're essentially deceased, but they still have to have perfusion. I would know that. Okay. And they are also extensively screened for diabetes, the same kind of things, hepatitis, HIV, TB, syphilis, severe hypertension, drug abuse. And they do get consent from next of kin. Yes?
So you were saying that they stop after feeding, so people that are like on life support and then the family decide that they want to take them off and donate their organs, do they like take them off then, like so the family can see and then put them back on?
No, that's not done. What they would do is you don't want to be the nurse to talk to the family about organ donation. That's not in your role as a nurse. What you would do is simply make the phone call at that point to LifeLink and let them do their job. And that's what they do best. And then the family can make that decision.
But I'm saying, like, if their organs have to continuously like be perfused, then when they take them off of life support, their organs aren't being perfused.
Right, so they would not be a candidate.
But if the family did decide they would keep them on the vent?
Yeah, they would have that conversation about organ donation with the OPO, and then they would make that decision. So yeah, and they are pretty quick. They will come right away. If you know somebody is a gunshot wound on a ventilator, you've already contacted LifeLink in ICU. So most of the nurses are aware to do that way ahead of time. And then they'll talk to, at the appropriate time, they'll talk to families about organ donation. So, but otherwise, if the nurses do it, it can be a conflict of interest. Okay, and we don't want to be in that position. And plus, we're not experts on it. Leave it to that those organizations that do this on a daily basis and help the families make that decision. Does that answer that? Did you have a question?
So when you say cadaver donors, they're not necessarily dead.
Right.
They're just brain dead.
They're brain dead. Yeah, but they're still
They're not
perfusing.
taking kidneys from people who are dead.
Yeah.
They still have to.
Cadaver sounds like they're
Cadaver sounds like, I know, they're called cadaver donors, yeah. Yeah. So, yeah, but if people live far away, sometimes they will keep that, they have just a certain amount of hours before they can move that. They'll keep the kidney perfusing as long as possible. And sometimes if they're far away, they may take it on ice to the location, but it's a matter of hours, So it's pretty close, but they are considered cadaver donors. Yeah, but for all intents and purposes, they are deceased. They're considered brain dead. And the physicians declare that. They may do an EEG to declare them brain dead. Any other questions? Good questions. Okay. So organs need perfusion, so the patients need to be on a ventilator. Again, like we said, extensive screening are done for these patients as well. And the families are talked to about it as well, because they have to get consent, right? Sometimes people will carry a card in their wallet, but you still need permission from the next of kin. But the kidneys can be preserved. The longest they preserve them is 72 hours. So, out of the body. So, but most surgeons will only transplant up until 24 hours because they want a high success rate, right?
What happens if their next of kin shows? Can we just take them after a certain amount of time?
If their next of kin shows?
Like never comes.
Oh, never comes.
Yeah.
I believe so, but you do get into some ethical issues, and you do have to go through your hospital ethical board.
They do that like on your driver's license.
Right, and then they would go with your driver's license if they can't reach anybody, and time is tissue, right? So, yeah. But they attempt to. They attempt to contact family. Okay. The longer the cold time, though, the increased risk of acute tubular necrosis, or ATN. And the kidney may take longer to start functioning normally, the longer the cold time. Okay. So management for pre-op teaching. We do like an emotional and a physical prep before surgery. We review the kidney function of the patient. Again, it may not be immediate before that kidney starts to function. They may still be on dialysis up until the surgery. And we're going to do extensive teaching, and we're going to talk about a lot of this is patient education for medications post-op, because the recipient will need to be on multiple types of medications, and we're going to talk about those: immunosuppressive therapy, and they need education on infection prevention, of course, and they're on isolation, reverse isolation, immediately post-op too. So we're going to teach them all that pre-op, right? Plus we're going to do your usual EKG labs, chest x-ray, and if they have a dialysis graft or fistula, we're going to take special attention not to use that arm for labs. Even though they're getting a transplant, we still have to follow those protocols. And you have to look at their hemodynamic status pre-op too. They may be like right before dialysis. Remember we talked about they're kind of on the border of overload. So they may need a pre-treatment that day, you know. It's hard to say. But you want to maintain and watch and monitor their fluid status pre-op. In the post-op care, it's usually, like I said, pretty minor surgery. A lot of times they can do this laparoscopically for patients. And they do a nephrectomy. They don't always, they typically will leave in a kidney. They don't always have to remove their kidneys. So, for surgery, yeah. So, the critical time is the first 12 to 24 hours. And of course we have to maintain fluid and electrolyte balance. And it can be as high as a liter an hour. So these folks are in ICU. Could you imagine emptying a Foley, doing hourly urine output, and being a whole liter every, or less even sometimes. So very large volumes of urine may be produced, because all of a sudden it's working, and then all of a sudden you can lose all this fluids. And they will replace the fluid for ml per ml. And how do we know it's working? How do we know a new kidney transplant is functioning good? Good, the creatinine. We're looking at our creatinine. That's our indicator, right? That's going to tell us when our kidney's working, is our creatinine will be normal. I would know that. Monitor your CVP readings. Avoid dehydration and hypoperfusion, right? Because what can that lead to? ATN, right? We don't want ATN at all costs. Acute tubular necrosis. Because that's a real bad disaster, right? Can I advance this? You guys still writing? Some complications like we talked about that can lead to ATN are long cold times with marginal cadaver donors. Sometimes we get rid of the fluid, but not always the waste products. And oliguria and anuria can still occur. So we're watching like crazy, especially in ICU, the urine output. We want hourly urine output. Sometimes there can be a clot in the catheter or a kink in the catheter or a urine leak. So we need to watch out for acute signs of rejection, which we're going to talk about, and obstructions, of course. So these patients are watched very, very closely. So the new diuresis is due to the new kidney's ability to filter BUN, which acts as an osmotic diuretic. So that's why they have so much fluid initially.
A urine leak, like in the surgical, like inside the person? In surgery?
Or that Foley catheter can leak sometimes. Yeah. So you want to watch it. If there's, some sort of blockage, sometimes that can happen. And gradually, the BUN and creatinine should return to normal. And again, urine output is replaced ml per ml with IV fluids. And they're also watching carefully their electrolytes, so they may be replacing that as well. Because sodium follows water, right? And then we were prone to electrolyte disturbances. So we've got to replace everything as well, depending on what our labs show. Okay. Okay. So post-op teaching, again, we're going to talk about immunosuppressive therapy, prevention of rejection, frequent blood testing. So these patients know already before they've had their surgery what they're up against. Patient education about rejection, what signs to look for. We're going to talk about rejection and how to prevent infection. They're on multiple prophylactic medications such as antivirals, antifungals, antibacterials, and a lot of these are nephrotoxic, right? So, but they will give them anyway, especially if the patients are higher risk. So complications, of course, are infection, rejections. We need to teach and assess, of course. Early diagnosis will prevent bad outcomes. The most common infections the first month post-op are pneumonia, wound infections, IV line and drain infections, and urinary tract infections. Fungal and viral infections can happen due to the immunosuppression. So these people, when their immune system is suppressed, they're prone to getting all kinds of viruses and infections. So we really need to teach them, and immediately we do put them on, like I said, reverse isolation to protect them, because they are immunocompromised. So they may be on prophylactic treatment like diflucan, Bactrim, antivirals like ganciclovir, Valsite. Cardiovascular is a leading cause of death after transplant. They have an increase in risk in atherosclerotic heart disease, hypertension, and dyslipidemia. And of course, smoking can contribute to cardiovascular disease. So just because they have a new kidney doesn't mean their cardiovascular status has improved, right? So they can still wind up occluding their vessels and the same problem all over again, which caused their initial problem in the first place, right, with poor circulation to the kidney. Okay. So other complications, of course, we have, what can we do, just a quick question, what can we do to prevent, teach our patients to prevent these diseases, like cardiovascular disease? What are we doing to teach them?
Adhere to their medication regimen.
Good. What else? Any other ideas? Right, heart healthy diet, good. We're watching our blood pressure, right? And what about plaque or fat in our vessels? Triglycerides are high. We're going to watch those and teach our patient to go get lab work done, right? Cholesterol panel, okay. And so what can we teach them about that part of their diet? Fresh fruits, fresh vegetables, right? Limited processed foods. Right? I know you all know I'm a nutritarian, and I kind of talk about that a lot because that can reverse their heart disease. So we want to make sure they have all those options open to them. They eat lots of fresh fruits and vegetables, beans, legumes, and keep a healthy diet because that can really save their new kidney, right? And hopefully reverse their disease because they have a new chance on life, right? And we want to give them every opportunity to keep that kidney as healthy as possible. Other complications are, bless you, malignancies, right? So the incidence of malignancies is a lot greater with this particular population. Why do you think that is? Any ideas?
They've already got a lot of stuff that led to kidney failure, maybe.
Yeah. The one reason is, yes, because of immunosuppressive. That's exactly right. When we suppress the immune system, we are more prone to getting malignancies. Okay? I don't know if a lot of you know that. I don't know if you ever watched Spartacus, but that guy on, he took steroids to boost his muscles, right? But he wound up getting cancer because he decreased his immune system, and then a cancer can overtake, and he wound up, I think he died, a young guy, and he was, but a lot of people do that, and they don't realize the consequences. So when you're that immunosuppressed, and long-term immunosuppression therapy can subsequently lead to malignancies.
So they're likely always going to take immunosuppressive therapy.
Well, I'm going to discuss that a little further, but they will likely be on. They do minimal now, and because it's gotten to such an exact science, they really know the limits of what to do before it can get to that point, which is really good. And they may put them on steroids for like a real short time because of that. And of course, like I said, you can have a recurrence of the original renal disease, like polycystic kidneys or like glomerulonephritis. Sometimes viruses can lay dormant in your body and then all of a sudden they come out again. And that's one of those nasty ones, right? And diabetic nephropathy. So these patients should be made aware that this can happen, that this is not a cure-all, that other complications can occur even with a transplant. Yes, it's a new lease on your kidney, lease on life, but complications can most certainly occur. And of course, from steroid use, that's why they really don't use a whole lot of steroids because of all the complications with steroids. And one in particular is aseptic necrosis of the hips. Okay, you all have heard of that?
No, never.
Then hips just kind of get necrotic because of the steroid, big doses of steroid use. I've seen people have bilateral hip replacements because of steroids. Peptic ulcer disease, we all know that. Glucose intolerance and diabetes, of course. You ever heard of steroid-induced hyperglycemia? Okay, so we're watching our blood sugars, right? Cataracts even, dyslipidemia, infections and malignancies, of course. And with the addition of the use, and we're going to talk about the drugs a little bit, but the tacrolimus is one of those drugs that that has permitted the decreased dose of steroids. So that has been a huge breakthrough for nephrologists with this particular drug. We're going to talk about the drugs. But tacrolimus, yeah. And we're going to talk about the drugs, but I'll give you a page number. I think it's 209 in your textbook. 211, sorry. Okay. So you can see these people go through such lengths. They finally get their kidney transplant, and then they come down with either more heart disease or malignancy or side effects of these medications, or they can have rejection. So you can see this is no easy travel for these patients. It's very rough going. They need a lot of emotional support, a lot of encouragement. The families need to be positive for their patients. But because of the advances in medicine, these rejections are pretty rare, but they do happen. And the reason for the immunosuppression is because the organs can reject. It's a natural immune response to reject anything foreign in your body. Okay? So it occurs as a normal immune response to a foreign tissue. And it is preventable with immunosuppressive therapy and with careful ABO and HLA matching, ensuring our cross match is negative. Prevention, early diagnosis, and treatment are essential to keep our long-term kidneys preserved. Perfect matching is impossible unless you're a twin, which actually the first case I believe was a twin back in the 1970s. And that was the first successful transplant. Interesting. You don't need to know that. It's just a FYI there. Okay, so hyperacute rejection. This is antibody or mediated, or also known as humoral mediated. So
that would be like the fastest, right? Maybe.
yeah. Yeah, hyperacute occurs within the first 24 hours of transplant because the blood vessels are rapidly destroyed. It occurs because the patient has had a pre-existing antibodies against the transplanted organ. There's no treatment. The organ must be removed. Thankfully, it's rare due to accurate typing and matching. And then there's acute, which is mediated by the recipient's lymphocytes, and that occurs the first 6 months after transplant. A cell-mediated immune response by the recipient's lymphocytes, which have been activated against the donated organ. So the humoral is the recipient develops antibodies to the donated organ. That's all that means. It's common to have one rejection, especially with cadaver donors or deceased donors, but it's usually reversible with it. But they'll increase the doses of a medication, like steroids or mono and polyclonal antibodies. They will give them those, and we'll talk about the medications. But again, these are going to increase infection risk and malignancy risk. And chronic rejection is a result of ongoing immune-mediated injury. This occurs over months or years, and it is irreversible. We don't really know why this happens, but it can happen. The transplanted organ is infiltrated with a large number of T and B cells, which indicate immune-mediated injury. Chronic rejection results in fibrosis and scarring, so treatment is supportive. Not a good prognosis. Here's a little slide that kind of goes over the types of rejection. This helps you kind of understand acute, chronic, hyperacute. Signs and symptoms. So if our patient all of a sudden develops pain or a temperature or an increase in blood pressure, and we notice their BUN, their specific gravity, are decreasing, and they're retaining fluid, what will we be suspicious of? Rejection, yeah, or infection. Something, right? Something's not working well with the kidney, right? So they're going to do extensive workups and treatments. So for chronic, signs and symptoms could be imbalances in electrolytes, fatigue, and of course, again, their BUN and creatinine is going to start rising. And it can be gradual. But they do keep a close eye on lab work, and that's how they know signs and symptoms of rejection if they're going to start rejecting. That's why they get frequent lab tests done. Okay, so we're going to talk about the goal of immunosuppressive therapy is obviously to prevent rejection, right? Suppress the immune response to prevent rejection of our transplanted kidney and maintain sufficient immunity to prevent infection. And you can see that's kind of a hard balance, okay, to accomplish for these patients. Okay. But you don't have to memorize all these medications, but just know what they are, what types they are, and know that you can tell when a patient is on just by looking at their medications, you can tell they've had a transplant. I can take a look at any one of my transplanted patients, and now they're doing a lot more of them where I'm working in particular. And I can tell if they're on tacromylus, if they're on prednisone, if they're on ganciclovir, if they're on Cellcept, all of those medications, Imuran, those are the ones that you should know are transplant drugs. Okay? Steroids, you should know the common side effects, like we just went over, of the steroids. Okay? So this is just a slide that shows you what the process of it, of the immunosuppressants. Okay. I'm going to stop there.